Welcome to Primary Care Today on ReachMD. I'm your host, Dr. Brian McDonough, and with me today is Joe Garbarino. Joeseph Garbarino is a pharmacist who works in the hospital setting. Obviously, he has to work with many physicians who are dealing with patients, inpatient, med reconciliation, and discharge, all those issues that we need to talk about in primary care he has to deal with. So, Joe, first of all, welcome to the program.
Thank you, Dr. McDonough.
Joe, my first question for you is, as a pharmacist, I think I've seen the role change over the years in my inpatient work. It seems like there's much more of a relationship between the physician clinicians and the pharmacists in the work they do.
Yeah, it's actually a great observation. You know, the role of not just pharmacists, but all ancillary care providers is evolving. And medicine is moving more towards a team approach and actually using pharmacists as drug experts on the team to kind of help the physicians on the team manage medications more safely and more effectively.
So when you work together, obviously there's levels of expertise and knowledge. Now, you working in a hospital setting for so many years, you probably have a pretty good sense of the common things that docs do and the common things they do well and do poorly. I want to start off by asking you, what are some of the mistakes? I mean, if you were going to look at physicians and say, in the hospital setting, errors that they make with regard to their use of medications, what are the common things that you see as concerns?
Well, I think first and foremost is dosing. Pharmacists many times optimize the dose the patient receives. What I mean by that is if a patient has renal insufficiency or an issue with their liver, many times they require a lower dose. So, many times the pharmacist will, in consult with the physician, or sometimes having automated policies to allow this, but actually lower the dose of the medication to dose the patient properly. The other issue that we see many times is drug interactions. So, just consulting with the physician to change the patient to the best drug possible to avoid a drug interaction.
So there are those types of things that happen. And I guess a lot of it is that physicians may not consider different risks or potential issues for the patients?
That's correct. I mean, many times physicians have so many other issues to worry about with the patient that, many times you can very easily overlook a dose. You can overlook a drug interaction. You can overlook not having a patient on the most optimal medication for a condition. Because as a physician, you're managing so much else. So the pharmacist can come in and help with that piece.
Now, as things are changing and evolving, and as you talk about it, as there's more of a team, I notice, for instance, in my hospital and in others where I visit, that you'll almost have, in fact, not just almost, you'll actually have a team where the physicians and the pharmacists are working together, doing rounds together.
That's correct. I mean, many times in your large teaching institutions, your very, very large hospitals, they were the first to have the medical team. But now even your smaller community hospitals, even your non-teaching hospitals, very frequently have a pharmacist engage in rounds with the physician. So it's definitely growing.
A lot of people in medicine, especially primary care, are turning to the hospitalist model. Depending on who's listening around the country, in fact, around the world to this program, when they are going to their hospitals, some may actually just work in their office and their patients may be taken care of by hospitalists. Others will be going and doing the traditional rounds. With the hospitalists taking charge in certain settings, what are some of the advantages and disadvantages of that you see from your perspective as a pharmacist?
We are definitely growing our hospitalist program in our hospitals. And the best thing for a pharmacist is access to the hospitalists. Hospitalists are normally employed by the hospital. So the pharmacist that works in the hospital has access to the chief of the hospital service. We as pharmacists can get messages out to the hospitalists. Let's say we notice that the physicians are dosing patients or not dosing patients for VTE prophylaxis. So we can get a memo out saying, please assess your patients for VTE prophylaxis and please choose the appropriate agent, whether it be like heparin or heparin itself. So it's just the access to the physician. The other piece of that, too, is education. Many times as a pharmacist, I'll provide an education lunch for the hospitalists where we pick a topic, maybe new guidelines for the new chest guidelines come out, give us an access to that to the hospital service. So to me, it's access more than anything else.
And I think when you're talking about access, you're also talking about a new generation of physicians who are coming up, who are probably used to being trained in major medical centers where this actually started and was happening even earlier than your community hospitals.
That's right. Also, too, since I come from a hospital residency program, many times after the third year residency, we'll use the residents, hire one of the residents into our hospitalist service as well. So there's a continuity there. I knew him as a resident, now they're a hospitalist. And, when working with me as a pharmacist or a member of my pharmacist team, they're a lot more apt to accept the recommendation because they're used to working with pharmacists in that setting.
One of the things some of the listeners may not know, as I mentioned it before a couple of occasions, but I work with the pharmacists on a committee in my health system, and I've learned a lot more about how pharmacists do their job. For a lot of physicians, what pharmacists do is almost invisible. I mean, a lot of the idea of taking medication, we just kind of write an order for a medicine, but there's so much more to it as far as the mixing and preparation, making sure it's the right dose, comparing the doses, or providing warnings. A lot of that happens in the hospital setting. It's more or less unseen, isn't it?
Yeah, yes, it is. A lot of the practice of pharmacy still happens in the quote-unquote basement of the hospital. Like we said earlier on in the program, you mentioned that, pharmacists are now more visible on the floors rounding with the physicians, and that is a new phenomenon that's been growing. But there's still, on the back end, the actual dispensing of the medication, making sure that the medications arrive to the nurse safely, making sure it's the correct medication, and all those checks do happen behind the scenes. So for a hospital to have a good clinical program, the hospital needs a good operations program as well.
If you're just tuning in, you're listening to Primary Care Today on ReachMD. I'm Dr. Brian McDonough, and today I'm speaking with Joe Garbarino. We're talking about pharmacy and pharmacy issues. We talk about med reconciliation at discharge, making sure the medications are appropriate coming in. Talk a little bit about the importance of that, and certainly it's a buzzword, but it's really gained importance for a lot of good reasons.
Yes, med reconciliation is very, very, very important. It's most important from a patient safety perspective. And it's something that everyone knows that practices in the hospital, say the Joint Commission and Institute for Safe Medication Practice, and many other organizations that are quality-based, are really, really encouraging and actually requiring med reconciliation to be done. Many times, as a pharmacist in my hospitals, we are involved in the reconciliation process. And we do find a lot of mistakes. We find issues with patients that they were taking at home may have been the incorrect medication, may have been polypharmacy. And then the other thing we as pharmacists do in med reconciliation is make sure that the hospital medications, so once the patient's admitted, the medication in the hospital match the home medication. Now, not exactly, of course, because as the medical condition changes in the hospital, you may want to hold the medication, you might want to increase the dose or change to a different one. But at least make sure for chronic medical conditions that they're ordered in the hospital. And then the other piece of that is making sure the patient goes home on the correct medication. Many times in the hospital, we switch medications on patients while they're in the hospital. Best example of those are statins. Most hospitals only have one statin on the formulary. So if a patient's home on statin A and we switch them to statin B in the hospital, it's real important to make sure that patient goes back home on statin A. And as everyone knows, if you have too much of a statin in your body, you risk rhabdomyolysis and other adverse effects that are very dangerous. So, patients are on very high-risk medications today, so it's real important that we get the exact picture of what they're on at home and then make sure they go home on the right medication.
And that is obviously something, too, that's being looked at as we go more to the electronic medical record. And as hospitals go to meet meaningful use, stages 1, 2, and 3, and more of them are becoming electronic. What differences has that made from the standpoint of pharmacy from your perspective? Well,
CPOE, or physician order entry, and the actual meaningful use and all the upgrades in technology have really, really impacted the profession of pharmacy and healthcare in general. From the standpoint of med reconciliation, what that has done for the pharmacists is get them an electronic way of looking at it. When I first started, everything was on paper. So for me to be able to know what a patient was taking at home, I'd have to search in the chart for the paper, hope it was in the right spot, and then try to find the doctor. Now electronically, I go to a computer screen, I bring up a patient's profile, right there are the home meds. So I know what the home meds are before I even go talk to the patient or even go talk to the physician. And that just makes it a lot easier. I think what technology has done for the pharmacist is really change their role and streamline their role. So earlier on, I was asked about the pharmacists that are behind the scenes, and that is true. A lot of us are behind the scenes, but at the same time, because we're more automated now, We no longer have to, type in the physician orders. Physicians are typing their own orders in. That gives us more time to be more clinical, be more visible on the floors. So that's one of the other things that really transition pharmacy practice from inside the pharmacy to the patient floor area.
In primary care practice, we often will get patients back from the hospital, and there can be confusing medications. There can be confusion for the patient. What do you suggest for docs who are out in practice to do to try and help their patients through that period of time and that transition from the hospital to home where they might get a little confused because the medicines can change? How quick should they be seen in the office? I mean, from your perspective, what would you have them do?
I would definitely always encourage a patient to follow up with their primary physician as soon as possible. One of the other benefits of an electronic medical record, and we're not there yet, I mean, technology-wise, as we do move along, meaningful use stages 2 and especially 3 will be a lot more connected. But, just having the patient's primary care physician and primary care office have accurate information on what the patient received in the hospital, have an accurate discharge summary, so they can actually go over everything with the patient. That's really paramount. Many hospitals around the country now have pharmacists involved in the discharge of patients as well. I know the VA medical system has done this for years and actually published literature around this, where they actually, before the patient leaves the hospital, they have a pharmacist talk with them. And then some hospitals go as far as to call the patient 48 hours after discharge and say, hey, have you followed up with your primary doctor? Do you have any questions? Are you having any drug interactions? Because many times with length of stay and other budgetary issues, we move patients out of hospitals 4 or 5 days, and sometimes they should be in the hospital 6-7 days. So those extra 2 days, they're still slightly acute. And just talking to them 48 hours post-discharge, making sure they're on the right medicine and making sure they follow up with their primary doctor, I think is very, very important.
One of the things we always talk about, and we've talked about on this program many times, is the patient-centered medical home, which is obviously a concept where patients can have their total care more or less coordinated through their primary care physician with all the other specialists involved, and pharmacy plays a big role there. From your perspective on that, where do you see going down the road pharmacists having an impact?
Well, I think that's a great question. Now where pharmacists as a profession is looking is to be more clinical outside of the hospital, to try to involve ourselves as pharmacists in large physician family practices throughout the country that have pharmacy representation in the outpatient setting. The American College of Clinical Pharmacy even has a board certification now in ambulatory care pharmacy. And really the whole purpose of obtaining that board certification is to be, gain experience and qualification to help the physicians and help the patients in the outpatient world. So definitely, I'm a big proponent of having one individual manage a patient's medical care, having the primary physician manage the majority of the care. It definitely avoids polypharmacy. It avoids a lot of the drug interactions where a specialist started something not aware that another specialist started something else. And pharmacists can play a major role in that. Another thing pharmacists can do in that setting is help counsel patients. Many physicians are very busy in their practice and may not have the time to really explain how to give an injection or sit down with a patient an extra 5 minutes and explain, yes, you should take this medicine with meals, or no, if you miss this medicine, it's not good, always make sure you take your medicine. Or even to follow up with the patient. If a patient, let's use a heart failure patient as an example. If a heart failure patient takes their diuretic and takes their beta blocker on schedule or ACE inhibitor, they can stay out of the hospital, and you can really, really keep them healthier and live longer and cut down on morbidity at home. So, that's another area where pharmacy can impact the outpatient world.
One last question while I have you here, and that is when you look at drugs that can get people in trouble, what are some of the ones you worry about that we as primary care docs should be thinking of and saying, be really careful when you prescribe these things?
I think the thing that gets us in trouble the most are medicines that we consider as benign, and we give them to patients all the time. The medication that has the most adverse events that brings patients to an ER was warfarin for a lot of years, and everyone knows, of course, dietary restrictions around vitamin K containing foods and the drug interactions with the CYP3A4 system of warfarin. The other one is the newer anticoagulants as well now are starting to bring patients into the hospital for adverse reactions. So definitely anticoagulants, to me, are very, very dangerous. And it's not so much the anticoagulant itself, it's the drug interactions. So many times we had a patient stable on Coumadin with a great INR for many, many years. They have let's say a UTI or maybe a bronchitis, and we start them on a quinolone. And there's a drug interaction between quinolones and warfarin, and they're in the hospital with a high INR. So it's not so much the drug itself. It's a lot of times drug interaction, but definitely anticoagulants to me are number one. And the other ones, too, of course, are chronic medicines that require just routine monitoring, like statins. You always want to look at liver function for those medicines as well. But if I had to pick one class, I would say anticoagulants.
Well, Dr. Joeseph Garbarino, a pharmacist who has really worked in the clinical world for a lot of time, I want to thank you. I really appreciate you joining us and sharing your insights on primary care today.
Thank you, Dr. McDonough. It was my pleasure.
This is Dr. Brian McDonough. If you missed any part of this discussion, please visit reachmd.com/primary care today to download the podcast and learn more about the series. Thank you very much for listening.